This is a portable, semi-sitting chest radiograph where the quality is not as good as your classic PA standing chest X-ray. However, many important things could be seen on such radiographs, one of which we could see here. Looking carefully, you'll notice that you have linear or curvilinear air lucencies in the neck. Here's a magnified view showing the air lucencies in the neck. Looking carefully, you'll notice that you have air lucencies here as well. Air in the subcutaneous tissue is called subcutaneous emphysema or surgical emphysema. The most important teaching point from today's case is that if subcutaneous emphysema is noted, you have to look for air accumulating elsewhere. By that I mean make sure that you don't have a pneumothorax, pneumomediastinum, or pneumopericardium. Although no obvious pneumothorax is identified on this radiograph, if you look carefully, you'll notice these air lucencies extending within the mediastinum. It's not normal to see air lucencies within the mediastinum, especially if the air lucency outlines the descending aorta. Here's a standard chest radiograph on the same patient with better demonstration of the air lucencies within the soft tissue and the mediastinum. And here's a lateral chest radiograph showing this abnormal lucency that does not correspond to the normal tracheal air lucency. Abnormal air superimposed over the hilar region and abnormal air anterior to the heart. So air within the mediastinum is called pneumomediastinum. This patient also had a lateral neck x-ray showing that the pneumomediastinum extends in the prevertebral space here. The CT scan on the same patient shows the subcutaneous emphysema and shows the pneumomediastinum. This is a coronal image on the same patient showing how the pneumomediastinal air could outline the descending aorta. Pneumomediastinum may result from trauma or iatrogenic causes such as line insertion or surgery. It could also result from iatrogenic or non-iatrogenic injuries to the esophagus or airways. It could also be seen with extreme strain such as vigorous coughing or weightlifting, and it could be idiopathic. In this patient, it was idiopathic. It's very important to make sure that the esophagus and tracheobronchial tree appear normal on the CT. Also make sure that there is no associated pneumothorax because a small pneumothorax may convert into a tension pneumothorax, which is dangerous. To summarize, always look at the edge of the film. Don't miss soft tissue abnormalities such as subcutaneous emphysema. If you see subcutaneous emphysema, make sure you don't have a pneumothorax, pneumomediastinum, or pneumopericardium. Abnormal linear or curvilinear mediastinal air lucencies that may outline the descending aortic contour are signs of pneumomediastinum. CT scanning is a better way to show these abnormalities, and if pneumomediastinum is seen, make sure that the esophagus and the tracheobronchial tree are intact. Thanks for watching. More cases later this week. The patient has this large heterogeneous and necrotic mass that invades and compresses the right side of the heart. As you see, the lesion extends to involve two chambers, the right atrium and the right ventricle. There's severe compression of the IVC. There is infiltration along the pericardium with a large pericardial effusion. There is an associated large right pleural effusion. A focal hepatic hypodensity is also seen. There are multiple lung nodules as well. Now, the most common intracardiac filling defect is a thrombus. The most common cardiac neoplasm is metastasis. That is 40 times more common than primary cardiac neoplasms. The most common primary cardiac neoplasm is benign and is called a cardiac myxoma, classically a well-defined lesion in the left atrium. Primary malignant cardiac neoplasms are less common, but the most common primary malignant cardiac neoplasm is a sarcoma, typically angiosarcoma. When would you consider a primary malignant cardiac neoplasm? The absence of a known primary malignancy, cardiac neoplasms that are malignant are very aggressive in appearance, meaning that they are infiltrative in appearance. They are more commonly located on the right side, may be homogeneous but are typically heterogeneous due to necrosis, involve more than one cardiac chamber, such as what we see here, the right atrium and the right ventricle, with complex and hemorrhagic pericardial effusions, plus minus pericardial or pleural thickening, and may show metastases such as involvement of the liver, the lung, or other organs. Everything together, this is a malignant neoplasm that involves the right side of the heart with pericardial effusion and hepatic and pulmonary metastasis. The patient is young and does not have history of a primary malignancy, which makes this a more likely angiosarcoma, and this was proven by histopathology. This was a good case for the seniors. Thanks for watching. More cases later this week. This is the diffusion imaging on the same patient, confirming a small stroke here, but this is not the reason I'm showing the case. Going back to the T2 weighted image, what I want to emphasize here is to always look at the vessels even though the study was performed without contrast. On T2 imaging, the normal vessels look very dark. This is what we call signal void on MRI imaging. I will simplify this without going into lots of physics. Since blood flows rapidly within vessels, you lose the signal there, and that's why there's normal signal void. So when flow in a vessel becomes slow, when there's thrombosis or obstruction, you lose the signal void. It is very important to make sure that the normal vascular signal void is seen. And looking carefully here, you'll notice this area of abnormality. This here is a focal area of signal void that is related to the internal carotid artery. Looking at a coronal T2 image on the same patient, you'll notice that this area of abnormal contained signal void is in the supraclinoid carotid. Remember that another good sequence to look at signal voids would be the proton density, and here's the area of abnormality confirmed again. You have probably guessed it by now. This is a left internal carotid bifurcation supraclinoid aneurysm. So today's teaching point is simple. For radiology residents, remember to always look at normal vascular signal voids on unenhanced brain MRIs. So this was a quick case today with a quick teaching point. Thanks for watching. More cases later this week. This is an elderly patient with a chest x-ray that has a neat finding that's good for discussion for both seniors and juniors. There are several hints that this is a cardiac patient. First, you see median sternotomy wires. Second, you see this device, which is called an implantable cardioverter defibrillator, ICD. Finally, you see cardiac enlargement. The main reason I'm showing you this case is to concentrate on this abnormality here. So this finding appears relatively denser than the adjacent structures. It has a curvilinear appearance, and it projects over the left cardiac opacity. To confirm the abnormality, let's look at the lateral chest X-ray. Can you see it here? And of course, you see it on the lateral chest X-ray as a curvilinear density that projects over the cardiac apex. I'm drawing over the abnormality here to make it more clear since it's a relatively subtle finding. The high density of the finding is consistent with calcification. So now you know you have this curvilinear cardiac calcification. What's your differential? The two major differentials would be 1, this is within the myocardium. 2, this could be within the pericardium. The commonest reason to have myocardial calcification is a previous remote myocardial infarction with or without an aneurysm. Now let's look at the CT scan of this patient to further characterize this abnormality. Here's the heart on the CT scan. I'll give you a chance to look at the findings. The CT confirms that this calcification is actually present, and it's involving the cardiac muscle, the myocardium. As mentioned before, the commonest reason to have myocardial calcification is an old myocardial infarction. It is well known that if you have an area of acute or chronic myocardial infarction, that this could affect the cardiac function and contractility in that region. Areas of abnormal motion are called in cardiac imaging hypokinetic, akinetic, or dyskinetic. Hypokinesia is decreased motion. Akinesia is no motion. Dyskinesia is paradoxical motion, meaning that the segment bulges while the remainder of the heart contracts. Have an area of regional wall motion abnormality in the heart, there is underlying stasis, and that's risk for developing a clot. Carefully here, you'll notice that there is an area of very low density that overlies the area of myocardial infarction. The density of this abnormality is even lower than the adjacent enhancing muscle, and this is indeed a thrombus. Knowing whether the patient has an intracardiac thrombus or not has a major implication on treatment and on prognosis, so this is an important finding. Please note that all these important findings are detected on a normal CT chest. This is not even a dedicated cardiac CT. So we learned from today's case that important cardiac findings can be detected on chest X-ray and on chest CT. If you see curvilinear calcifications, think, is this within the pericardium or myocardium? The most common reason to see myocardial calcification is an old myocardial infarction. This may or may not be associated with an aneurysm and is commonly associated with hypokinesia, akinesia, or dyskinesia. Since you know that's the case, even on a static chest CT image, try to look for a thrombus because that's important for treatment and prognosis. I'll finish this case by answering a question that might have crossed your mind. Since many of these patients are imaged after being known cardiac cases, you might think, why would we care for such findings? Remember, first, you detected a thrombus that might have been missed by other modalities, and this is important. Second, remember the population that gets silent MIs. These are the diabetic populations, and this is a very, very common disease in our society. So don't be surprised if you are the first person to tell the clinician that his patient had an old myocardial infarction nobody knew about before. This is a nice, neat, and simple case with many teaching points, and it shows you how amazing radiology is. Thanks for watching.